Good evening, everybody, respected chairs and my fellow faculty and the students here. So in the tune of what we've been talking about with semaglutide, we now have a little difference, and this is disclosure. And we're now going to focus on what the American Heart Association has recently penned down called the CKM syndrome, which means cardiovascular, which is obviously the brain, heart, and the kidney, and metabolic, which we all know is diabetes and obesity, and link them into a syndrome. This particular syndrome has a very, very high adverse cardiovascular outcome, and this syndrome is really linked, and this is something that we always knew, but we never had the evidence for it. Now, the CKM also now has stages, and the stage 0 is when the patient is completely normal. Stage 1 is when adipose tissue starts getting higher, and as all we know and we've been hearing, that adipose tissue is the driver, or obesity is the driver for all the cardiovascular events over and above the traditional risk factors. Now, stage 2 is when you get all the traditional risk factors in, including hypertension, diabetes, so on and so forth. Stage 3 is when the risk factors set in. You do a calcium score, it's positive. You do a BNP, it's positive, but patient is asymptomatic. And you do a UACR, it's positive, but patient is asymptomatic. And I would believe that stage 2 and 3 is the place where all our work and efforts as physicians will bear fruit. But when you come to stage 4, the damage is already well established, and you have obviously end-stage disease in all the organs. So this is a great way to really look at a patient, and if they're in stage 2 to 3, there is an opportunity for us to use medication, lifestyle, and move ahead. Now, the GLP, as you've already heard in the last 2 trials, is a major driving force across the organs, including at the brain level, where it reduces appetite. At the heart, we know it has a very good anti-inflammatory property, decreases liver fat, increases insulin secretion, and finally at the kidney, acts as a diuretic. Now, the good news is that from 22, from the KDIGO, followed by the EASD, and then the European Society in 24, and finally at the EASL in 24, they have recognized this problem, and they have also recognized that the use of GLP-1 receptor analogs is the way forward, and it's come into the guideline. Now, we have heard about the subcutaneous form, and now we're going to look at what is the evidence with the oral form, which is Rybelsus in India, which is the oral semaglutide. Now, extensively studied over 19 trials, 6,000 odd patients studied, 7 out of 10 achieved their goals. The Indian data with diabetes, whatever we have, is about 3 out of 10 or even lesser would achieve HbA1c goals, and the story is similar with hypertension, where not even 17% of our for patients with hypertension will achieve goals. And if you look at the HbA1c reduction, it's not 1.5, but it goes up to almost 2.6% when you use Rybelsus, and you're also getting an incremental weight reduction of almost 5 kilograms. And when you look at it with the comparator molecules, the competition, so to speak, you will see that across the board from Pioneer 1 to 8, Rybelsus is achieving goals in almost 40% of the patients, and the closest one, which we know is empagliflozin, is really just about halfway through. So you're getting 2 benefits. One is you're getting a big HbA1c benefit of more than 1%, and you're getting a weight loss of more than 5%, which is good. But what is even better as an add-on is you're getting CV risk reduction, and that's what as cardiologists we are interested. And we know that most of the myocardial infarctions is because of inflammation, and we now know that even heart failure is driven by inflammation. The marker we also know as hsCRP, and the good news is that Rybelsus gets that down by a significant number. The lipids are down, the blood pressures are down, and more importantly for Indians who have normal BMIs, our waist circumference is coming down. And the good news was that we achieved the approval for this drug in India very quickly. The CDSCO, or our Premier Drug Control Authority of India, gave this approval in Jan 2024. It was the 5th country to get the approval, where you could use this patient who is more than 18 years of age. He had to be diabetic as a first line, could use as monotherapy or as a combination. Especially, you could even use it with SGLT2, with metformin, could use it in special populations, and more importantly, you're getting a lot of cardiovascular safety. And the initial experience with India, and this is real-world data that we have called the Pioneer Real Study over 44 weeks, clearly showed over 400 patients that a good number of patients were started as a first drug. Most of these patients had obesity. They had a high glucose, 8.9 was HbA1c, and 50% had cardiovascular disease, which is a big number. And what we got in that short period of time is a good HbA1c reduction of 1.78% and a weight reduction of almost 7 kilograms compared to the comparator. And so the conclusion was that Rybelsus or oral semaglutide had very good sugar control. There was good body weight reduction, no red flags coming up with this real-world sort of experience. And those patients who got it got the dual benefit of HbA1c as well as weight control. And therefore, Rybelsus came to India, got that clearance, and now we use it fairly regularly. Now, just moving on in the same direction, the SOUL study was the first study to show Rybelsus, which is oral semaglutide, and they wanted to look at the cardiovascular benefit. So about 10,000 patients across, 10% of them were Indian, so good numbers of Indians represented, and the usual step up of 3, 7, and 14 that we've been hearing about was used, and they were looking at MACE. The patients, as you know, 70% male, they were elderly, 25% were Asians from Asia, which is pretty good for a drug because we know that most of the drugs have been studied in Caucasians, fairly high-risk patients, high sugars, high BMI, long-standing diabetes, large number of them hypertensive, the typical patients that we would see in our outpatient clinic, and most importantly, significant cardiovascular disease, 70%, and a good amount, almost up to 50%, had renal disease. Luckily, most of them were above 30 mils per minute. Well-treated patients, fairly well-treated with the standard of care, I would say, 80% RAS, almost 80% antiplatelets, and obviously they were well-treated with diabetic medication. Almost a third were on SGLT2, which I would say is standard of care. And despite this, the semaglutide arm, the oral semaglutide arm, showed a significant reduction of 14% MACE, which was CV-related death, non-fatal MI, and stroke. And the benefits accrued fairly early within the first 6 months, and the lines continue to diverge with an NNT of only 50, which is really good. And most of the benefits on the MACE was good for cardiologists because the non-fatal MI reduction was driving this reduction. And across the board, if you look at the subgroups, we are seeing the superiority with oral semaglutide. Especially two groups really benefited, and that were patients who had a higher level of HbA1c and Asians. Again, good for us because it's very applicable to our population. But more than the CV benefits, we start getting the renal benefits. Not too much, but 9% in that population, very reasonable. And the 5-point, I think we are calling it the MAKE now, the major adverse kidney effects. So you're getting GFR decrease is getting smoothened. Getting CRT is less, and if you just look at the trajectory of GFR, it's down by 32% compared to the comparator, and even if you had a higher GFR or a low GFR, you still had a decrease in the overall decline and reaching a dialytic stage. And then small real-world study, this is Spanish data, similar kind of patients, 63, they had a USCR positive. And here, interestingly, over I think about a year's time, they found that the USCR specifically comes down. So you're getting a USCR benefit. The GFR was fairly similar throughout, but you're getting USCR benefit. And USCR basically means you're just getting the renal slope is sort of decreased, and we know that USCR is a very important marker when you add it to the GFR when you're talking about renal risk. And UFR decrease is also seen with the new non-steroidal MRA, and we see that the GLP seems to be having a similar benefit. Now, no major red flags. In fact, the SAEs were actually more with the comparator arm, more by infections and infestations, but the AEs were more with semaglutide, and we know that we've been having this problem from SELECT, and the gastro issues continue to dominate, and it's been sometimes very difficult to step up on these patients. Now, in a patient with diabetes who has a CKM, we have 4 molecules that we would traditionally use and we have been using. And if you look at glucose-lowering efficacy, weight reduction, CV reduction, the pleiotropic benefits, and more importantly, hypoglycemia, I think there's only one drug that stands far above the rest, and that's oral semaglutide. Thank you very much for your patience here.